Hello everyone, and while I share my screen, I'm going to welcome you all, panelists and participants alike, and a very special participant today is Annie's dad, who's in hospital. So we hope that Annie's dad is watching it and he's well. Hello to Annie's dad. So if I share screen. So today's webinar, and there are several hundred of you on it, which is fantastic, is on patient safety priorities for 2022, beds, backlog and bureaucracy. And we've got two stunning presentations from Annie and Jono, but we've also got time at the end for questions and answers and discussion. So we've allowed at least 20 minutes for that. So please do stay on and contribute. We've got a poll as well to get your insights. And there is a live discussion box to the bottom right hand, apparently, of your screen. Please, can you click onto that? And that will give you the chat, the space to ask questions, and also the poll when that comes up. So hopefully that's clear. So I'm going to start with the format of today, which is three presentations, a relatively shorter one from me on the systems and global perspectives on patient safety. Annie will be talking about the operational reality and Jono the patient perspectives. But actually, as we've developed our presentations, it's strange how the themes are very similar amongst us all, but from different perspectives. And as I say, question and answer session at the end. So I'm going to dive into my session now. And just to remind you, if you don't know, I'm Helen Hughes. I'm Chief Executive of a charity, Patient Safety Learning, an independent organisation that supports and promotes systemic change and the reduction of avoidable harm. So what we talk about is listening to and promoting the voices of the patient safety frontline. That's both the patient voice and the staff voice. So we'll be hearing that today. And that we also try and support improvement and sharing good practice for patient safety through a range of different ways, through how-to resources. And one of those that many of you will be familiar with is about sharing knowledge for learning and action, our free learning platform, The Hub, that has lots of content. So please do join, learn, share, give your insight and help us support that social movement for patient safety. So I'm going to focus in the next few minutes on the global health system performance, patient safety issues. And my insight on this is informed by some work that the World Health Organization are doing. They're producing a report towards the end of this month, which will be looking at COVID and the patient safety issues and implications of that. It's the first report of that kind, I think, anywhere that's been done. And I've had the honour to be part of a small expert group that's contributed to that. So these aren't WHO slides, they're my perception, but they are the context by which we need to consider the patient safety issues as we're going through recovery. And they will be, some of the themes, as I say, are reinforced by Annie and Jono's presentations. So let's remind ourselves, huge disruption of services in all sectors. And we know that some of that was about ceasing services and refocusing entirely on acute care and responding to the pandemic, maintaining some services like cancer services, but long-term care screening services were paused and for relatively long periods of time. We know that there were diagnostic and treatment delays, and that's very pertinent today because we know that in the UK, 10 million people stayed away from accessing care, and the recovery plan that has been launched this week assumes only half of those will represent. So if more than those represent, then we've got even more challenges for our recovery plan. So there will be kind of safety issues as part of that. We clearly reprioritised activity during the pandemic, and we focused, I think, collectively and globally. There's a view that we reduced our focus on patient safety, and part of that was that focusing on the immediacy of responding to the pandemic, that many people who work in patient safety are clinicians and were redeployed into the front line. And we also know that staff were not able to report incidents because of their sheer volume of work. So we don't have a very good insight into the scale of avoidable harm during the pandemic. The insights that we do have, and some of the reporting systems like in Pennsylvania, have shown a significant increase in reports of avoidable harm. So that's something we've yet to discover. Some of the leadership and governance issues, I think, and again, these are thematic across the world, but we weren't prepared and we weren't as resilient for the pandemic as possibly we should have been, and there will be many inquiries in the healthcare systems around that. But the safety issues are huge as a consequence. That lack of preparation meant that our patients and our staff weren't able to be as supported as they might have been. And we need to learn and reflect on that for any pandemics that are potentially likely to come. I think there's a greater understanding about the supply chain issues and how supply chain is a safety issue. And our discussion today is supported and sponsored by BED, who've been very active in this field. And we're doing lots of work through patient safety learning, doing lots of work with NHS Supply and others, looking at supply chain issues of patient safety perspective. And I think that's a lesson we've all learned. Huge challenges of working across health and social care, worthy of a webinar in its own right. But I just want to focus on recovery planning and delivery, and the importance of prioritization for patient care, but for patient safety. Do we have the knowledge? Do we have the data? Do we have the risk assessment tools? Are we engaging appropriately with patients and with families, giving advice to make sure that we are minimizing avoidable harm? We know 1 in 10 people experience avoidable harm, and there are significant WHO, it's one of the top 10 leading killers in the world, avoidable harm in healthcare. So we do need to put patient safety at the core of any recovery plan. Massive challenges around health information and communication as a societal issue. Huge misinformation around vaccine programs, a significant concern that people are losing trust in science, and that we don't have adequate information and data on patient safety, as I said before. But there have been many positive developments that have come through the pandemic, and we mustn't lose those and the opportunity to work new. Jono will describe it in a bit more detail, but from the broader thematic and systemic issues, huge delays in diagnostic and treatment across all sectors. It really has exposed the long-standing structural drivers of health inequalities. We know that both in terms of people getting COVID, their treatment, both staffing issues, but we know that whether by race, by age, by health literacy, there are significant parts of our population that have been affected more directly from COVID, but also the consequential impact of availability of services. And that really must inform how we develop our recovery plans. Massive mental health impacts for children, and we still have yet to fully open up our acute hospitals. So we know isolation and visitation impact is a significant patient safety issue. Patients and families can spot when things go wrong and can alert staff to that. Not having patients and families visiting compromises the ability to catch those or to raise issues and to prevent future avoidable harm. And I think it's significant that when we talk about the recovery plan, we're not looking just at acute care. There's a recovery plan for community and social care that is due, and I'm very hopeful that that includes the huge implications of people living with long COVID, and that is incorporated with it, and then they aren't the forgotten patients from COVID. So in terms of health and safety of staff, I think a much greater understanding that staff safety is a patient safety issue, and the first World Health Organization, or the second World Health Organization Patient Safety Day in 2020 was about staff safety. Huge issues about the supply chain, inadequate PPE, significant issues that will have a longer term impact of people's training being compromised. And I know some of the Royal Colleges are very concerned about what impact that is going to have on medical training, and I'm sure that's across all professions as well. Annie will talk much more about the burnout, fatigue and moral injury to staff during this time, and that we are going into this hopefully post-COVID recovery phase with enormous staff shortages and staff under pressure. I think the latest figures in the UK are staff shortages of 93,000, and we still don't have a workforce plan that will address that. That's a significant patient safety issue. And of course, not to forget, not only the people that died, the patients that died, but in the first 15 months, it's estimated 180,000 staff died globally in doing their jobs and catching COVID, either in the community or probably most likely through their work environment. So patient safety is a critical global issue. This will be reinforced in the WHO report. Significant increase in avoidable harm is undoubted, but yet to be fully quantified, and we may never discover that. But what we talk about in patient safety learning and through our blueprint to action policy work is that patient safety has to be a core purpose of what we do. We have to design our recovery plans with safety at the core. It's not a consequential additional task that we need to do. We need to build it in. And that's for patient safety, but for staff safety. So refocusing our current patient safety initiatives to make sure that they're contributing to the challenges, because many of those initiatives were started before the pandemic. So I think it is time to kind of pause and say, how do we continue with those? Do we prioritize or reprioritize those given the context we're working in now? And I would argue, and this is something that patient safety learning have been developing on, that we need to set organizational system standards for patient safety so people know what is expected and they can design that in. And I've included those sort of 7 foundations that we've designed into our standards. So that's my kind of system and kind of global perspective that provides the context. And now we're going to do a quick poll if the technology works. So there are many national patient safety initiatives as part of the NHS patient safety strategy, such as the new patient safety syllabus and the patient safety incident response framework, PSIRF. So I'm going to stop sharing because I think that will allow the poll to work. So I don't know, I'm not sure, Kareem, who's our tech expert here, is the poll up and running? Can people contribute to that? I do hope so, because I can't see it on my screen, Kareem. So I'm hoping that participants can. Annie, can you see it?
I can't actually, but
so we were hoping we would get the poll because that would kind of provide a bit of context, Annie, for your presentation. But if we can't see that, hopefully you can do it. It's just us as the panelists, we can't see it. Oh, the poll is on Swapcard. Fantastic, brilliant. If there's a way of actually sharing with us the results of that, Kareem, it's not on Zoom, so that's why we can't see it. Okay, if there's some way of letting us know through the WhatsApp chat what the result is, then that will be great. So I'm going to pass now to Annie for your presentation.
Thank you, Helen. Can you see my screen?
Yes.
Okay, hello everyone. Thanks for inviting me today to speak on patient safety priorities for 2022. I'm a consultant in anaesthesia at the Royal London, which is part of Barts Health, and I'm also on the National Safety Standards for Invasive Procedures Committee too, which is part of the Centre for Perioperative Care. And I'm currently doing a QI coach course with Barts Health and the Institute for Health Improvement. So I first of all want to set the scene. We all know this, but the past 2 years have been extremely challenging for acute care workers. We call ourselves the COVID warriors. We've really faced our fears. We've worked in this is a team of consultants that I was working with, Team C, night after night. We've stepped up, we've delivered COVID, and I just think we should remember what it's been like. You know, at the peak of the pandemic, I looked after 5 patients with COVID who ended up on intensive care. Really busy, really stressful, a lot of strain. And I know nationally and locally colleagues have been in similar positions. So that's just setting the scene of where we are now. And we mustn't forget that, you know, we're tired. You know, and then when we come to our title, beds, backlog and bureaucracy, you know, beds were an issue before COVID. And so this isn't really a new thing. And now it's more of an issue. And I just wanted to share some of the WhatsApps. I mean, this is a daily occurrence, you know, recovery is full, check with them. We're going to have to close these theatres. We're only able to do life or limb. 6 patients in recovery overnight still unplaced. You know, we've got a massive flow issue within the hospitals, and that does create safety problems. You know, patients end up on the wrong ward, you know, a ward that may not be specialist in caring for their particular problem. They end up in recovery for not 1 but 2 nights, and this is happening nationally everywhere. And on the back of that, you're more likely to have staff off sick or shortages, because it's not as attractive a deal really working, you know. And often my colleagues and I are in recovery till 11 at night waiting for a bed. So the list may have finished on time, but actually the impact on our lives and our working day is significant. And this document, the Operational Pressures Escalation Framework, OPAL, you know, describes OPAL 3 and 4 as, you know, really severe operational pressures, and that's the new normal, and that is everywhere, as far as I can see, in a lot of organisations. If we then think about the backlog this week, this is big news, 6 million patients waiting, and of course, this is awful. But the backlog has actually been getting worse since 2011, and COVID has made it even worse. Obviously, there's a risk of the backlog patients not having their surgery, but there are also risks of targets, sort of pushing the system harder when it doesn't have the capacity to be pushed harder. And so, you know, when I looked at the document that was released last night, I did a search for how many times safety is mentioned in the document, and it's mentioned once. And I think we need to remember, you know, the systems approach. We need to think about how we can safely deliver the volume and the reality we're facing. And that is going to involve some really, you know, systems thinking and using some of the models like the SEEPS models to really understand the system. We're now talking about 104-week waits. So we used to, you know, 52-week wait was the target. Now we're on 104. So it's much longer waiting lists. And as a result of that, some of the solutions are things like pooled lists, so that the consultants don't know the patients, they're being consented on the day. And you can see how that could create some safety issues for the teams and for patients. The hub and spoke models are a good idea, but and other innovative ideas, but they are new ways of working and will come with risks, which I don't feel we fully have understood. The longer days we're being asked to do, the 3 sessions, do have an impact on our safety, human factors. Working longer times isn't necessarily good for this workforce that's already in crisis. So I think we can openly say across the NHS there's a crisis of efficiency, safety and flow. So how can we reduce the backlog safety? Well, first of all, let's recognise the issues. You know, if we have teams coming together who don't know each other, the care isn't going to be as safe. I've done a lot of team training of perioperative teams, and we always say a team of experts is not an expert team. And I don't feel that that's been fully addressed. So we need to create expert teams and keep them together. So you might have a high volume list and get a group of experts together, but they might not work well as a team. You know, we've seen high numbers of agency and locum staff coming together and staffing shortages across the specialties. This obviously creates risk, and that is because people are fatigued. There's this COVID burnout, and we're also being told put your wellness first. So you know, avoiding extra shifts, knowing that we're, you know, not at our A game. We need to look at the system and understand success and failure in a much more wider kind of way. And we're still dealing with COVID pathways. We've still got red, amber, green pathways, which create much less efficiency in themselves. You know, we need more system infrastructure support for clinicians. You know, if you have an improvement idea, how are you actually going to get it to fruition? So we need to work with, you know, improvement teams and project managers to really get these projects over the line and meaningful, big change rather than small little projects. And we need to address some of our resources, particularly around, in some organisations, the IT systems slowing us down. You know, are we too busy to improve? This is what it feels like, this classic picture from improvement, that we're still trying to roll, you know, a square, and we're too busy to look and take the wheels and really think about what we're doing in a systems way. And it feels a bit insane trying to just push the system harder, do the same thing over and over and again, and expecting to get different results. You know, so how are we going to address the risk? Well, clear processes. I mean, I've worked a lot with on the NatSIPs, the National Safety Standards, and those are clear processes that give us reliability and safety, because the teams know exactly what steps they need to take to deliver safe, reliable care. And yet, in many organisations, people still don't really see the value of checklists. And, you know, it's a tick box exercise. We need to really have clear processes. When new staff come and new teams are put together, very good inductions, bringing them together. This is how you work safely. We want to listen to you, and working with teams. So good induction, clear standard operating procedures, and for them to have the ability to influence them and sort of cut down barriers to work. Much better governance. Like, what is going on with governance in our organisations as we address this backlog? Do we have resource governance systems that are fair and just? I think we need to really look at what we're providing on the ground around governance. And with that comes the movement, civility, around civility saves lives, kindness and inclusion, including everyone in the team, to really make this a reality. You know, learning from excellence, which organisations are doing this well, what can we learn from them, and having real systems intelligence to understand what the impact of, you know, reducing the backlogs in one hub centre is going to have on the spoke. My passion has been MDT team training, but it's still not part of what we do. We do not train as teams, we train as tribes, and this needs to change. And this is in many of the documents, but hasn't translated into real change on the front line. We need a lot more improvement support, and that support should be more than just coaching, but actual delivery and better infrastructure around IT. And of course, you know, today more than ever, as Helen said, my father's in hospital. Our patients are at the heart of what we do, and they're focusing on them is key, and maintaining the quality of care. So yes, there's volume to be dealt with, but we need high quality care. And our patients can see the pressure we're under. The people who have been sympathetic to, you know, our theatres have been the patients saying, sweetheart, are you still here at 11 at night? Why are you still here? I saw you at 7 this morning. And they can see the pressure we're under. And that actually, this people really understanding now that happy staff are safer, and we need to really, really focus on our staff wellness. And we will need compassionate and innovative leadership who aren't just target driven, trying to beat a system harder with a stick. It's just, I don't see it working. You know, the bureaucracy, this recovery plan, you know, it's great ideas, but does it translate into action? I'm looking forward to seeing some of that, but it will need to be innovative. And as we've already mentioned, this patient safety strategy and the National Patient Safety Syllabus are amazing visions, but they're a different planet. On the ground, has it caused a lot of change? Well, we're going to see what the poll says, but I would suggest that people have been focused on other things. And it seems like this doesn't integrate into the recovery plan and the wider system. And it certainly hasn't been resourced adequately to provide real safety change for the front line. I love this slide because this is it. Workers imagine these big documents, big bureaucratic documents come out and imagine how people are going to work. Then it goes into policy and it's prescribed. But workers done is completely different. The work has done is what we need to be focusing on, what is actually going on. And this actually needs to be done by people coming to see the front line and you know, not from a Teams call. So I would suggest that organisations should focus on three main things: people, and that's our staff and our patients. what are the processes behind it, using some of these documents like the PSERF and the NatSIPS2 and safety strategy to really deliver safety locally, using specialist documents like this Mind the Gap in maternity to really drive, and take learning from national projects, and really integrating systems thinking, human factors experts, and having the data to help us really improve around our performance. The work with is very powerful. This is Pat, who's our Deputy Director of Improvement at Barts Health. And she said, I want to come and work with you for the day. And it was amazing for her and for me. And she came, said, I'm going to come and see workers done. And she could see you can prescribe anything in a policy. What happens on the floor, you have to take the team with you. You have to bring quality improvement to your teams and seek to understand the issues they're facing. And that's, being just to the teams and doing right for the patients. We have a wonderful family working in these areas. This is one of our team training exercises where we really sought to listen and understand what the issues are. We have a wellness program where we have yoga and mindfulness, and this has proved to be very important in staff retention and creating a culture of safety. And we have a family. We've supported each other through a difficult 2 years. We need to tap into that love and that, truth, rather than trying to beat people and making them work harder, and look after them. And this is we've had some various charitable donations from the Drapers and other companies to give us food, to look after us. It's been really well received. So in summary, in the words of Drucker, culture will eat strategy for breakfast. And we need to remember that, particularly at this time. That is certainly the attitude of the front line. Let's get the culture right, look after our staff, and the strategy will follow. Thank you.
Helen, we love you dearly, but you're on mute.
There had to be someone that did it, didn't it? It was me. Thank you, Jono. I was just saying that I've logged into the same platform that the participants can see now. So I've got the results of the polls. Thank you very much for people, for your comments and for your questions. Keep those questions coming in. We'll do those after Jono's session. But Annie, I thought I would read out the poll results, because I think it reflects some of the issues that you've raised. And Jono, you might want to reflect on it as well, in case you haven't got it. Let me have a look. So how many people said, yes, I feel confident and steps are being taken in my organisation to deliver these initiatives? That was 36%. No, there has been no movement in my organisation to deliver these initiatives, 36%. And then the one that was focused on the individual participants, I don't understand what is required of me regarding these initiatives, so 27%. I don't know if the language of that has confused people. I don't know whether that's, I don't understand is 20%, 27% saying they don't understand, or 20% saying they do. So I'm not quite sure about that. But any immediate reflections on that, Annie, and then I'll link to Jono.
Well, I think clearly a lot more needs to be done to support these initiatives. And I think when we spoke yesterday, Jono said, there hasn't been enough resource, and he can see these sort of initiatives definitely need resource to really be taken up by trust and delivered in a meaningful way.
Thank you. So I'm going to pass over to you, Jono, and I know from having seen the run through yesterday, you're picking up some of the very practical themes and issues and issues of compassion that Annie talks about so strongly. So I'll pass over to you for your presentation. And then we'll have a 15-20 minutes sort of question Q&A panel discussion at the end.
Okay, thank you ever so much, Helen and Annie. I completely agree with you. When we look at the three things that we were asked to touch on, the situation is bad out there. And it's been bad out there for a while, but I want to bring you the feeling and the the thought from a really recent but also regular patient perspective. I have the joy and privilege of being both a long-term conditions patient with cystic fibrosis, but also a member of staff at NHS England. So let's just be honest, I see both sides of the door, and actually I see unhappiness on both sides of that door at the moment. And I want to just try and touch on those and how this is impacting on both. So it's, for me, I want us to start right at the beginning, because we have these issues, but when we have these issues, what is the core of why we're trying to resolve them and how we need to resolve them? Because it's great that we can sit here and say, oh, bad times are here, aren't we all having a terrible time? And it's true, but actually the only real way to deal with safety and to encourage safety is to look forward and see what we're actually going to do. But the thing that we're always told in safety culture is know the problem. And the problem at the moment is the 5 things that I absolutely say are key to every single patient journey are not being done. So the 5 things that I need you to understand are here on the right hand side. Patients, and I know every single staff member I've ever met, want their patients to receive the right care. But we're not always receiving the right care because we can't get to that care that you wish to give us. We need that care to be delivered in the right place. And that's the right place for the patient, not the system. So we need to maybe be adapting and learning and modernising the way we deliver care. We need that care to be in the right time. And that is crucial and is the hardest thing for everybody at this moment in time, with all of the impacts of the pandemic. But let's not just throw the pandemic as an excuse at this. These systematic system problems have been with us for years. And I will be the first person to say, I am fed up with the NHS being used as a political football by politicians who want to do their thing that they like. Actually, I'm sorry, the NHS knows what's the best approach to it. The NHS and their organisations delivered the vaccine, not politicians. The NHS are the people, and the people at the heart of it are you, the staff. And I'm just a wonderfully grateful patient. So actually, let's leave it to the experts and stop people messing with our system. We want the right person to be delivering our care. And only when you have those 4 rights do you get the 5th right, which is the right outcome. And I don't know anybody who works in healthcare who doesn't say, I want the right outcome for my patients. And that right outcome should be the right outcome for the patient, for the system, for those caring for us, for our families, our friends. So let's look at beds. Let's be honest about the bed situation. The pandemic was not the thing that has caused the bed situation. We go back 30 years to when I was a teenager right in the Brompton Hospital being diagnosed for the first time. And we look at the number of beds, almost 300,000 beds were available to the NHS in 1987. 141,000 in the year 1920. That's a more than 50% cut in the bed space available to the NHS to deliver care. And we were told when those beds were taken out of hospitals that there would be community care, that we would be reinforcing from secondary care to primary care and making a better care system for us. But let's also be honest, we've seen a 43% drop in district nurses. GPs are telling us they're on their knees. They can't open up back to full capacity because of staff being off, because of unwell, because all the reasons that have driven them to this point. So actually we have a holistic problem across the whole system, but it's a problem that we need to learn about and resolve together. And I don't actually think the NHS can do it on its own. It does need political will, it does need the finance, but it also needs us as patients to understand where the NHS is and how we can support it by being better at looking after ourselves, by supporting ourselves, and by having those around us be much better at helping us to be the best patients we can be. So mea culpa, we need to take some responsibility as well for helping the NHS to get back to where it needs to be. There are long waits. I sat in a meeting the other day and was told, you know, isn't it terrible that we've got now 2-year waits, the 104 week. And I said, hold on a minute, guys. In the Southwest, we reported our first patients having a 3-year wait last week. And, you know, it's a small number, half a dozen of them, but 6 patients in the Southwest region on a waiting list for more than 3 years. Large numbers on a waiting list for more than 2, even larger for more than 104 for the 52-week wait, which we used to say was a good wait. There's lack of information for patients. There's a lack of flow. There's a lack of sharing with each other what is actually going on. And patients are confused. And patients are upset when they get phoned up on the day of their surgery when they've been told that it's all going ahead and prepared, and suddenly it's not. And they get told at 7 o'clock in the morning, don't come to the hospital, there's not a bed for you. We need to be much better at informing patients and caring for patients in the way that they need to be looked after. We need to think much further ahead in our planning. I've said here that waiting is not just a simple calendar ticking down. Whilst we wait, we get worse. We know about deterioration. We know that patients are deteriorating as they wait, and we're not placing safety at the heart of waiting well. We're not allowing patients to feel safe even in their own home because there isn't community care and there isn't nursing staff to support. And even those that do or don't have family around them, those family are not being appropriately trained in safety. Those family are not being appropriately supported to do the job properly. In Cornwall, we have hospitals paying family to take their family members home and spend time with them. That's a disgraceful situation that we are in, when we're having to pay our family members to take time off of work to come and do the care that should be being provided by care support staff. But it's a situation that we're in now, and we will be in for a while. So patients are deteriorating. We're not seeing safety in our homes. We're not even thinking about, as we wait, the secondary conditions that apply. People who wait for one surgery often require another later on because they've been put much more pressure on alternative joints. You know, we think about, I'll talk about my own mother-in-law. She has been waiting for a hip replacement, which hopefully will go ahead this week, having been cancelled for the 3rd time. But whilst she waited, her knee deteriorated so much that she now knows she needs an operation on her opposite knee, which means we've made them wait so long that the deterioration has caused another need and another person on the waiting list. No physio support at home, no great care, just look after yourself until you get the op. These aren't great responses, and we need to support patients more in making themselves as well as possible ready for that wonderful time when our wonderful NHS is able to help them. And we're placing a burden not only on the patient, but on the whole system, on the healthcare system as a whole, the care system in the community, on our friends, on our family. And let's be honest, even on the third sector, we're asking charitable organisations to step in and help, and they are doing a wonderful job. But we're not paying them to provide the help. We're not giving them the funding to provide the help. We're just asking them to find their own resource to do it. We need to be much more open about the cost of healthcare to everybody, the community and the system. And it's much more than we're currently getting. So what should our response to these backlogs be? Well, let's just be honest. I've said it already. We need to think about rehabilitation and prehabilitation, being ready for this wonderful surgery and these wonderful interventions that the NHS are going to give us. We need to talk about waiting well. Hate the term, but understand it. Whilst you are waiting to have the intervention that you need the support and care to wait well. You need the support and care to do really good things. Let's be investing not just in the surgical hubs that have been announced, but why aren't we investing in community physiotherapy, community occupational health, and community services to support patients in their home to stay well, get in, and even recover and get better whilst they are on the waiting list for the surgery. all we're actually doing is extending the wait and making the surgeries more complex, longer waits in hospital after surgery because the surgeries have become more complex, and we're burdening ourselves even more by not preparing ourselves better for our time that we need. And what should that include? It absolutely must include personalised care. Personalised care, as defined by the NHS, includes social prescribing, it includes health and wellbeing plans, and we need to be reviewing patients on lists much clearer and much better to ensure that they are properly supported to have a full health and wellbeing plan that looks after the whole person, not just the part that we're about to do surgery on. We need to ensure that they have social prescribing available to them so that as they wait, they're supported by the work that's being done in the community and some great social providers. And bureaucracy. You know, bureaucracy is needed. I have no doubt that we do need governance. We need good, clear, safety-related governance. And I'm proud, actually, that I was, if you're very sad and you've still got a paper copy or a digital copy of the patient safety strategy, I'm very proud that at the very back of that is a list of everyone who contributed. And my name is listed there as a contributor, as one of the people that wrote the patient safety strategy and the parts specifically relating to patients being involved in their own safety. Very proud of that. And as Annie said, that it was visionary. But I will tell you today, and I've not said this in a public forum before, but I will tell you today, if I knew now what I know, if I had known then what I know now about the fact that there is no resources being put to this and that there's no support for senior staff to do this well, I would not have put my name to that document. It is visionary, it is excellent, it could be brilliant, but only if it's resourced, only if it's given the credence and the dedication that it needs to be delivered, and only if patients are properly and truly involved in the design and in the delivery of all patient safety aspects of that report. We talk about, I've got here a little quotes from the National Quality Board, very senior board, very senior executives, made up of all of the organisations that think about safety in the NHS. And the bottom one I'll just concentrate on for 2 minutes. It says co-production with people using services and public and staff, meaningful engagement ensures that people using services, the public and staff, shape how services are designed, delivered and evaluated. And you'll see I've added in red, written with minimal co-production. And the reason I've written that is because I was at the co-production meeting for that document where patients were told you can only comment on slide number 6. Ignore the rest, that's for us to deal with. That's not co-production, that's consultation at worst. So I actually did say to the National Quality Board, you got it wrong, you did a bad job, you should do better. How can you ask others to be held accountable for public engagement if you don't do it well yourselves? And I'll say it again, the National Quality Board is not doing public engagement as well as it should do. And therefore, there is little strategy being developed with true co-production around patient safety. We need to do better. I, as an organisation, within my role at NHS England, need to do better. I, as a patient, desperately want you all to involve patients in safety as much as possible. What's in your best interest is in my best interest, and I'll finish with these 3 points. Patients absolutely need to be active partners, not just partners, but active partners. And that means part of the MDT, part of the multidisciplinary team that looks after and is involved in safety. Patients need to be there and need to be engaged at all times. And Annie, I love your point about the fact that we're not training as teams, because we're not. We're training in silos, we're training as individuals, but we're not coming together. And there's one comment I've seen in the chat box about Swartz rounds and the way that we should bring people together for safety reviews. That's about bringing a whole team, every person together. And I would say that even at a Schwartz round, you should involve the patients. You should involve people who are engaged in every aspect. So please get them involved in their own care, but also please get them involved in strategic decisions for your organisations. I've said here, in hard times, we need to support each other. We need to support everyone. I was saddened when 3 weeks ago I was in hospital and one of the nurses came in and was close to tears before she even got in the room. And while she was setting up an IV, we had a conversation where she said she felt unsupported, uncared for, stressed, desperate to go home. And when she was home, she was desperate not to be at home because she was so upset with what had happened at work. And that is a disgrace from our senior management, to allow our staff to feel so underprivileged and undervalued. We need to do better at supporting our staff in health and well-being. We need to do better at saying thank you. We need to do better at giving the care to our staff in the same way that we give to our patients. And on the last point, I simply say thank you is the least I can say to you. You have kept me safe. You have kept me alive. You have given me your all, and I wish to give you the same. The words thank you are not enough, but for me, and on behalf of those that really love you and care for you, thank you for all you're doing. You are wonderful, caring, loving people who have dedicated your lives to others. And I wish that we could give you as much as you give to us. Safety is the first thing we should give you. So let us do the right thing and promote patient safety for both patients and staff. Helen, I hand back to you.
Oh, thank you, Jono. Really compassionate, passionate, informed, insightful, and challenging in the best possible way. I'm gonna turn to Annie for the first question, and I'm going to ask the questions that are coming through in the chat room or in the question session. So do keep those coming in. Annie, your experience of co-production, you talked powerfully about we're training as tribes, not teams, and we're not probably engaging maybe patients in that training as well. So what's your experience of as a professional in your clinical role, but also in your leadership role with NatSIPs, the value that co-production has brought to you and any kind of insights and reflections you have on that?
I mean, I think it's absolutely critical, the perspective that I've gained from having patients in there. And I think clinicians are naturally kind of problem focused, diagnostic, and actually patients can bring a lot of solutions to the table, innovative ideas. So I think in the kind of production, patients are absolutely critical, but in the actual care delivery, I mean, if I take, some of the safety checks in invasive procedures, patients are the missing link. If they can actually articulate and tell us what the issues are, I don't feel safe, my consent hasn't been done properly, this arrow, why is it on my leg, can you check this, and understand the sort of safety checks going on, that's really powerful, and they're a really important role in helping the team deliver safe care. So I think co-production, I've tried and gone to patient panels and got involved with patients, but the more I'm involved with patients, the better my work's become, the better our work, the solutions come. And hearing Jono, inspirational, and other patients that have got involved with patient safety that I've worked with have been absolutely inspirational and have become friends. Really powerful stuff. Thank you, Annie.
And Jono, I want to come back to you, particularly on the focus on the bureaucracy, the slides. And it was a very, very open and very honest contribution you gave about your role in the development of the National Patient Safety Strategy. And despite its ambition, the challenges of realizing it and realizing it without resources, even before, the challenges of COVID and the pandemic. What's your sense of how the NHS is responding to the recovery planning, the reorganisation that's going on with ICSs? Where do you see that the co-production agenda has got in that? Is that front and central with patient safety, or is that still something that we have yet to convince people to change their ways of designing and delivering new ways of working?
So as far as the ICS development goes, I would say we are well and truly behind the curve. During the pandemic, nearly all patient facing staff, and what I mean by that is patient involvement facing staff, so patient engagement, patient involvement was curtailed tremendously during the pandemic, and staff were moved into support roles and other roles, and anyone who was clinically based, of course, was absolutely right that they should be placed in a clinical setting first. And so we are well behind the curve with where we should be with engagement for ICS development, and we know the ICS framework has been pushed back to, I think it's end of June, beginning of July, because of parliamentary issues. Let's not go there. And when it comes to patient safety as a whole, we haven't been as engaged in the patient safety framework development going forward as we should have been. And I think actually patient safety partners, which we wrote as a visionary point, it will be amazing if and only if organisations are supported to get them in place, and they should be in place in all organisations, not just secondary care. They should be in place in PCNs. They should be in place in the ICS. So primary care networks, the integrated care systems, all need to do much better at patient engagement and patient involvement as a starting point, but absolutely need to do better with patient involvement in patient safety.
Thank you. And I do wonder, I mean, if there's lessons to be learned from what was a very good initiative around, the Speak Up initiative many years ago, because when you invite staff to speak up, you have to organise around the fact that they will be doing that, and you have to facilitate that people will be listening and taking action on that. So it isn't just about establishing, in my view, the patient safety partners. If they're there and the way of working hasn't changed, and staff, their teams, and organisations aren't responding to the opportunity to listen and learn from patients, then you'll end up having people frustrated because they're not able to make the difference if co-production isn't being designed in. You
talked about the patient safety incident reporting framework, just to show you where patient and public involvement comes on the tree, if you like. The element that's been most delayed in the patient incident reporting framework is the development of the platform that will allow the public and patients to report incidents.
Yeah.
The side of the trusts are getting their ducks in a row with this fairly soon, but the public access to that has been delayed, and that sort of, to me, tells you where the team is thinking.
And to putting it into context, 20 years ago, when we were developing the National Reporting and Learning System, the intention was to have patient reporting as part of that. And that was 20 years ago. So yes, if there is that commitment, then there needs to be some action to realise it. And I know it's technologically quite a challenge, but we've got big issues in that. And the MHRA have been, in my view, rightly criticised for the yellow card reporting system and their response to it, because for medical devices and pharma, that system hasn't been as effective as listening and responding to the voice of people that are raising concerns. I'd like to turn to a question from I think it's Helen Clothier, and she talks. She gives us a specific answer. Example, but really about the culture of organisations and the culture of organisations in promoting patient safety and indeed staff safety. So she asked the question, and I don't know which one of you want to go first on this, but I think that any reflections on the particular point that Helen makes, and indeed the wider culture, would be valuable. So she says, some senior nurses bully patients and staff. What can we do to stop this? It makes staying in hospital stressful and lonely. maybe Annie, you'd like to pick it up. Get your final slide of, Drucker's culture eat strategy for breakfast. Here's a very tangible and specific example about why that's an issue that is so important to be addressed to prevent avoidable harm.
I mean, I think that the whole compassionate leadership piece, I think it has to come from the top, the compassionate leadership, although you can try and, feedback locally, unless you have support from the very top of the organisation that is compassionate, that they want to listen, that certain behaviours won't be tolerated, and that, they recruit with those sort of behaviours in mind. It's very difficult to turn the tanker. And I think as a staff nurse on a ward, it would be very difficult to really, make that change because of the hierarchies. So the compassionate leadership and breaking down hierarchies to enable that just culture is what we need.
And Jono, any reflections from you? Because Helen identifies the issue of patients feeling bullied too.
Yeah, absolutely. So let's start with that comment. Bullying is not allowed in the NHS and should be dealt with appropriately. And it should be dealt with by approaching the staff, raising it as a concern, and if needs be, going through the correct governance approach of talking to the Freedom to Speak Up Guardians, which you've already spoken about. Let's also look at culture as a whole. It is incredibly difficult for organisations to demonstrate high quality culture when those that are assessing them for that high quality culture don't demonstrate it themselves. So as you said, it comes from leadership, so it comes from the top. We know that HSIP has recently been criticised for its internal culture, and they, at first, when they visit, will always look at culture of an organisation. So that will make it very difficult for them to hold people to account in the future if they don't have the right culture themselves. And when it comes to culture, on my desktop, I keep and always have, and I've just clicked to open it, the Nolan principles. That's the principles of public life or people in public office. And I believe that as NHS staff, we are in public life. We hold a public office because we are paid for by the public. And I want to remind people of that. So the Nolan principles are quite simple. 7 principles. You need to be selfless. You need to have integrity. You need to have objectivity. You need to be held accountable and have accountability. You need to have openness, you need to have honesty, and you need to demonstrate leadership. And for me, culture starts with those 7 things. And where we don't see it, we need to change. And the only way to change is either to train and develop people correctly right from their early stages of their career, or actually sometimes it's time to say goodbye to people who are not demonstrating the correct culture. It's a bit harsh, but I'm sorry, I've had it with people that are doing this the wrong way. We need to be caring and loving. And if you're not in those two environments, please go work somewhere else.
Very powerful. And I think I've been having Twitter conversations with a number of people this morning about whistleblowing. And, there should be no whistleblowing in the NHS. We should be embracing and engaging the feedback. Most people are very sincere when they raise concerns, and we should be responding to those appropriately. We've only got 2 minutes left, so we can't have a very long discussion for another question, but any final concluding points, Jono and Annie? You've given us a huge amount of insight. I'd like to reflect before you do. I think the slide you showed, Annie, about the Steve Shorrock's different work as, and work as imagined and work as done. I think what today's session has shown from your perspective as a clinician and leader in patient safety, and Jono's as a leader in patient safety and in terms of patient participation, the gulf there is between work as imagined, work as done. And I love the idea as the work with, so that our leaders could actually understand what is happening on the shop floor, so to speak. So that would be my takeout, to get people seeing what it's like directly, and not envisaging it from a distant part of the system. So Annie, Jono, kind of 30 seconds.
My final reflection would be, I want to be positive. I truly believe the NHS is an amazing thing, and I truly believe in our teams and our people, but I just want to have a little bit more support, a little bit more listening, a bit more that work is done, bringing our patients with us. And I really feel that the future is bright and we can do it. So I want to leave on a really positive note, and with bodies like Patient Safety Learning and people actually really rallying around to make this a reality and really listening, we can do it.
Thank you, Annie. Jono?
I love the fact that Annie says we can do it. We absolutely can do it. We can do it together, and we can do it powerfully and well. And you know, for me, the two things to take away. One, if you are a member of staff, please get onto ESR and sign up to do the patient safety training from the patient safety syllabus. Levels 1 and 2 are available now. You really should, if you're interested in patient safety, just go and do that and see what is being put out and bring yourselves up to speed with what is happening. And two, like Annie, I say we can do this. We can do this together. It is very sad that it comes to places like some great people like the HSJ who have and BD who have sponsored this to actually raise patient safety issues. We should be doing it ourselves. Helen, the Patient Safety Hub is an amazing resource and people should go and visit that. I'm very passionate about the work that you do. So thank you very much for what you're doing through that, helping people to see the incidents that are out there now. And finally, I will always end with this one. Thank you.
Thank you. Excellent. Thank you all. Thank you, HSJ and BD as well. Goodbye all.